Doing that. That's weird. I think we're on. If not, I think I did this last year anyway. So, which I think is up there somewhere. I never took it down. Okay, so here we go. Analyzing the latent image. Someone want to hit the lights for me, so you guys can feel peaceful and relaxed. Okay, so. Jasmine, we'll talk. We have a couple of things. Anyway, no, not major things. All right, so here we go. Resolution. So, real quick, when you look at an image, we can break it down into kind of resolution, but resolution breaks down into contrast resolution is one big item that you can kind of separate and think about, and spatial resolution, right? And a third is artifacts, but it's really like the absence of artifacts, right? So when we talk about overall resolution, it's the combination of spatial versus contrast resolution, and we'll define those a little bit more soon. Of course, we always want the best resolution we can get, right? So here comes some of the reviews. Variables affecting exposure not to the patient now, okay? This is exposure to the image receptor. The reason why we're talking about exposure to the image receptor is in subsequent classes, it's going to have a lot to do with how the image is reconstructed by the computer. Right? So when MA goes up, well, exposure goes up, right? Easy enough. I know. I need sound effects like. Okay, exposure time. Similar to MA, when the time goes up, then exposure goes up to the IR. And to the patient in many cases, but it's not always exactly the same. Right. To give you an example of that, right? You can put a very low dose to the patient and give the patient, a certain amount of radiation that the plate doesn't receive because it never makes it there. Right. So it's not always the same. Okay, so we spoke about exposure time, or did we? Directly proportional, as well as MA. Double the time or double the MA, and the exposure goes up. Mass, which is the product of MA and time, if that goes up, then we should know that exposure goes up. Right? Half the mass, half the exposure, right? Directly proportional. KV is proportional, but not directly proportional. It's exponential. Right? You can go up in KV about 15%, which is not doubling it, and the exposure will approximately double. Right? So a little bit of KV goes a long way, thus the big arrow versus the other ones. So far, so good? Nothing new? All right, good. It even went up slower because it's heavier. Okay. Variables affecting exposure, again, to the IR. So this one is, it depends, right, on the generator. So if the generator is more efficient, has what's known as less ripple, gives you a harder beam, then you don't need as much exposure. Right? So if you were to, let's say, have a technique that works with a less efficient generator, okay, and now you move to a more efficient generator, but you don't change your technique, that results in an overexposure to the patient, right? And technically to the image receptor as well, right? So the rule is, if you have a technique that works with a less efficient generator, moving to a more efficient generator should allow you to reduce your MA, your time, your mass, right? Yes. Okay. All right. So how about filtration? This one's kind of weird, right? I always get a lot of heat about this one. Right? So this is the assumption that there's a patient there, okay? Because if you do this experiment with no patient and then just add filtration, then the image receptor will feel different things, okay? So let me explain. So if we use filter, not compensating filtration, filtration that's placed into the tube, right? The magical number, 2.5 millimeters of aluminum equivalent. We all have that buried into our heads. The image receptor should feel about the same amount of radiation, whether you have filtration or not. Because the theory is, without the filtration, some of the longer wavelengths get stuck in the patient, never make it, or don't even make it to the patient, die in the air. Thus, your image receptor feels a certain amount of radiation. Now, if you take out the filtration, maybe a few will not die in the air, but the majority will still get stuck in the patient. Image receptor receives the same amount of radiation. Right. So the question is really, what is happening to the remnant beam? Because the remnant beam is the amount of radiation that's coming out of the patient. Right? It's kind of like between the patient and the image receptor. So the filtration, again, should change what's in the remnant beam. Any questions on this one?
The filtration is only taking away the weaker, effectively,
Yes,
the weakest stuff, so that it wouldn't get through anyway.
That's right. So the filtration is only taking away the longer or weaker photons that would get stuck in the patient anyway. That's why I kind of prefaced this, because if you don't have a patient there, right, and you just do this experiment in the lab with no patient, and you take a digital dosimeter and you measure the radiation, sure, if you put filtration in, that radiation number is going to go down because you kill a few photons, right? So there's a difference whether you have a patient in the way or not. Of course, the reality is, in clinic, you're not taking pictures of nothings, right? So there's always a patient there, or a part, at least. Okay. Field size, basically collimation. So when we collimate less, which means the field size increases, then we have more scatter. Some of that scatter never makes it to the image receptor, but some of it does. Whatever it does will increase the overall exposure, right, to the image receptor. That's why we should usually do the opposite, right? Collimate more, meaning field size smaller, meaning reduction of scatter, and then if we do that, then exposure goes down to the patient and to the image receptor. Good, good, good? Okay. Variables affecting exposure, like part thickness. So not much you can do about the part thickness, right? Patient is what they are. But if the part thickness increases, in other words, you go from a smaller to a larger part or patient, then exposure goes down simply because they have more molecules in them, essentially. Right? That fat has a little extra molecule built in, which will automatically kill some of the photons. Right? They'll get absorbed photoelectrically, and then won't make it to the image receptor, and then exposure goes down a lot. Right? Patient condition, pathology. So we know all about this from trying to figure out what question might have been on one of those midterms or finals last year, right? So we know that not all pathology is the same. Some is, what was it, destructive versus constructive, I think? Oh, additive, sorry. So essentially, though, pathology, depending on what it is, requires either a decrease in exposure or an increase in exposure. In reality, I like to bring reality into the class a little bit. Based on our systems now, between photo timing, which we discuss later on in the semester, but you may have seen it already, automatic exposure control setting in certain cells, and digital imaging in general, which really increases the latitude or margin of error, you can almost pretty much leave your exposure the same. Right? And have a good exposure indicator and all those nice things. But the reason for this in general is why give the patient more radiation than they need? So if you know they have a destructive type of pathology, like a pneumothorax, which requires a lowering of technique, then you should lower your exposure a little bit rather than increasing it. or keeping it what you usually do. That's where automatic exposure control is really helpful, because it automatically shuts off or terminates the beam once a particular cell senses the radiation has gone through the part. But that's a whole nother lecture. But really, that's the gist of it. Turns off after the cell feels the radiation. It's a little bit more complicated. You have to set the correct cells and make sure you got everything right. Have you guys seen photo timing, especially like in chest x-ray, like in a standard chest x-ray room? Yeah. They're always going from the two outside, detectors to the middle when they switch to the lateral. No? Some of you?
Yes.
Yeah. Well, we'll talk about when we get to AEC, but one of the big things about that is if you mess up and you have the two outer cells, but you do a lateral instead, bad things happen. I'll leave you guys wondering. Okay, scattered radiation that is in the remnant beam. Did we just talk about this? Interacts with the EIR? Well, yes. Okay, grids. If you use a grid, whatever ratio it might be, exposure will go down. Photons die. The lead lines kill photons. Not only do they kill the scatter, but they kill some of the good ones, which is why we have to increase our exposure technique to have more, for lack of a better term, good photons in the mix, right? So that's why we have to increase our exposure. Not just to make up for the scatter, but to make up for actual mostly parallel photons that get killed. And that's why as we go to higher and higher grid ratios, we have to keep increasing our exposure technically, because the little gap between the lead lines keeps getting smaller and smaller and smaller and killing more photons, even if they're not diverging that much. Anode heel effect. So there's more exposure towards the cathode end. Again, we don't see this as much in digital imaging because it's sort of corrected for. This particular phenomenon manifests more the longer the bone is. So, you're not going to see this on a hand. You might see it maybe on a fib or a femur, more likely. So the rule is to place the larger part of the anatomy, the thicker part of the anatomy, towards the cathode to take advantage of that. Again, hard to duplicate and see it with digital imaging now. My class becomes more and more obsolete each year. Right. Soon it'll be like all the digital stuff handles it. Like, do you really think about what's happening when you take a photograph with your phones now? It's like, who even has a digital camera anymore? Unless it's like super, super, super good. Right? I had a 1.5 megapixel digital camera. I think even flip phones have that now. Okay. And not the new fancy flip phones, like the old flip phones. All right, SID. Well, we should know that just for this lecture, right? For the quiz that you already had. So if SID goes up, you're further away from the image receptor, more photons die in the air, literally, hit air molecules and get obliterated. And so exposure goes down, right? A lot, right? Because it's based on inverse square law. All right, so that's why the big arrow is there. OID, as OID increases, again, we're going to have less photons hitting the image receptor because that OID allows for some divergence of the remnant beam. So some of that remnant beam coming out of the patient, when I say coming out of the patient, I'm always, in my mind, I'm always thinking of a patient like supine, right, with an image receptor behind them, and they're kind of levitating off of it. So that beam that comes out of the patient diverges. Some of it's going to diverge off of the image receptor, not all of it. But theoretically, some of it does, and then exposure goes down compared to if you didn't have any OID, or if you had less OID. Good, good? I might have to juice up with some more caffeine soon. Okay, KV. So now we're switching, though. Now we're switching to contrast. KV has an effect on contrast. We don't see it as much. Again, it's not as relevant as it used to be. But for the record, just in case you get a question somewhere, not just from me, we can always say up KV, down contrast. Maybe not a lot, maybe not recognizable anymore, right? Which is why we can generally use higher KV. because we're not worried about increased scatter having a major effect on our image, because it gets corrected digitally. But technically, if you imagine you didn't have these digital corrections, KV increases scatter, scatter adds like a fog or a blanket or more noise, however you want to say it, it degrades the image, right? So contrast would go down when KV goes up. But that's not a reason to lower our KV anymore, right? So now, in fact, we've actually increased our KV from standard techniques. Like a hand used to be 52, now you can do it at like 62, right? That was unheard of in the past. You would get an image that was really bad. What else did I want to mention? Oh, well, if you go down too low in KV, because the opposite is true, right? Lower KV, higher contrast. But if you don't have enough KV to penetrate, then you're out of luck, right? So there's only so low you can go. But again, we don't have to go low anymore. It's better to increase KV, right? You increase KV, you get less photoelectric effect. In other words, more radiation gets out of you, which means less gets stuck in you. And I know I'm running out of time probably, but I can't help myself. When I was a student and the professor was like, and the photons get stuck in you, and you keep getting x-rays and they keep getting stuck. I never really got that. I'm like, am I walking around with like photons from the x-rays I've had? Where are they stuck? Where? And then I went to a lecture, which is why it's nice to go to conferences and stuff. And someone addressed that issue, and he said, Daniel DeMeo said, well, they don't really get stuck, but what happens is you increase proportionally your chance of getting cancer, right? So it's not like they get stuck, but whatever, I mean, it was still not the clearest thing, but your chances, your potential of bad things happening genetically and whatnot, or to DNA strands, increases with subsequent x-rays. Not that they kind of like accumulate somewhere. You can go and rip them out. All right.
Not yet.
Not yet. If they're there, I don't know where they are.
So that just means like over time, more x-rays you get.
Right. So your maybe I'm not quite using the best semantics. I would say your cancer risk becomes cumulative. Right. Okay. So where were we? Generator is. So the way you want to think about contrast and the generator is when we say that the generator is more efficient, what you should be thinking, the easy way to think of this, without overcomplicating things, at least for this class, because you have a class about the generator, so I don't want to take away from Professor DeVito, is think that the KV, without you actually manipulating it, changes, even though it doesn't really change. It's just that when you go to a more efficient generator, instead of having maybe 1/3 of the photons being at the level of the KV you actually set, you actually have a much higher percentage. So in a less efficient generator, let's say a single phase, that's kind of like the worst ones out there, and there are probably not that many out there anymore. If you were to set 100 kV, you get about 33% of your total photons actually at 100 kV. As you go to more and more efficient generators, that percentage increases and increases, right? So with the most high frequency generator that's out there, you set 100 and you get about 98, 99% of your photons at 100, which means you don't need to use as much exposure, like we were talking about before, when you go to a more efficient generator, because you have more penetrating x-rays, thus you'll have more x-rays in the remnant beam, more x-rays interacting with the image receptor, and more data points for your reconstruction overall. Again, this is not as relevant in CR or DR, because not only do we get an image with a certain level of contrast, now we can window that contrast by changing our scale, either shorter scale versus longer scale, and we can manipulate it, and so can the radiologist. They can even have multiple images at different scales, right? They don't have to pick one and say, well, you know, and lose all the other ones, which is kind of cool. All right, I think I got to speed up a little because I didn't get into the new stuff. So I got to get to the new stuff. In clinical application, protective filtration added to the tube shouldn't have an effect on contrast, right? Same rationale that we talked about for filtration before. Compensating filter, which is utilized for like a foot or spine work. This is where we talked about the filter being taking away only a certain amount of exposure from a certain spot. That's different than the kind that you put directly in the tube, right? This is talking about doing, let's say, a scoliosis series, and you have one exposure to do C, T, and L spine, right? But you know you don't need as much radiation here, so you put in a compensating filter that absorbs some of the radiation cephalically, but leaves it open down posteriorly in your lumbar area, let's say, where you need more radiation. Right? So you use a level of radiation that's high enough for the thickest part you're doing. Can't work the other way around. Does that make sense? Mm-hmm. Some of you? Just nod, make me feel good. No. All right. Field size. Again, it's related to scatter. So if the field size is increased and we have more scatter, that's going to reduce contrast. That's why we always like to get rid of scatter. Not only is it good for the patient, but it's better for the image. Part thickness. So even when you increase your exposure for a larger patient, let's say, contrast still goes down. Let's keep going. Patient condition, same thing. Contrast will go up or down depending on the pathology. Scatter radiation. Well, we kind of said this already, right? Scatter up, contrast down. That's why we like to reduce scatter, to get scatter out of the way so contrast can go up. I'm glad I was not getting videotaped there because I moved my hand in the wrong direction for a second. You'll never know. Of course, yes, you will, because now you'll listen to me saying this, because I'm not editing this.
They told us.
Yeah, I told you already. I shouldn't have said anything. So use of a grid, pretty obvious. Use of the grid reduces scatter. Reducing scatter increases contrast. Okay, I can keep going. OID. OID, some of the scatter diverges off of the plate, and thus contrast goes up. This is essentially the same thing as an air gap. Of course, the problem is magnification also goes up. Are you finally getting to something interesting? Okay, motion. Motion has kind of changed over the years. When you have motion on an image, anyone see motion on an image yet? Just one, two, few? Okay. It shows up kind of like a blur, but it's not considered minification or magnification, right? Because things don't get larger or small. You're not manipulating OID or SID. So you're not going to have any foreshortening or elongation. So it doesn't really fall into like the distortion that we normally think of when we think of the word distortion. It's been described in a few different places, but also in your book as false images. And you kind of want to think of it as, instead of getting one PA hand image, you really get like 50 of them overlapping. And that's what causes that blur. So when motion increases, contrast goes down, of course. And so does overall resolution. Spatial resolution goes down too. And it's really hard to fix motion, right? The only thing we can do to try to prevent motion, as you probably already know, is reduce exposure time and or talk to patients. Yes, I guess there's, I don't know, what's the politically correct word? It's not restraint anymore.
Mobilize.
Immobilize?
Yeah, immobilize.
I usually localize. All right, I'm going to skip the next few slides because they're a summary of everything we just talked about. So you can read these, but they just sum up what we spoke about. I'm going to get to penumbra. So your book uses these trace diagrams. They're kind of weird and hard to figure out, and you have to read them a bunch of times. So I'm just going to try to sum things up for you, but they're called exposure trace, and you need to kind of understand the lay of the land, kind of like the map that has like the little thing in the corner that tells you that blue is a lake and whatnot. So you need the legend. Is that it? The map legend? So the next slide here is where you really get the map legend on the trace diagram. So the background exposure is based on this height here. The subject contrast is actually in the middle. But we are actually, for the purpose of this lecture, because this is used in a few different chapters, we're going to be paying attention mostly to this triangle area and really to that diagonal line that you see going on over here. And we're going to look particularly in the next couple slides at the slope of that, right? The steepness of it. So we already said contrast was kind of in the middle. Penumbra, we said, is this slope right here that we're going to concentrate on. So here's the main part here. The steeper the slope, the less the horizontal spread and the sharper the image. So the steeper the slope, the less penumbra, the better the image, right? We all know, right, penumbra is bad. Penumbra is blur. So we don't like blur. Blur is distortion. So this is a slide I want you to pay the most attention to. So you have three trace diagrams, and you're looking at the slope of, what is this, trapezoid? Who knows their geometry? Slope of this line, basically super steep. Doesn't get much steeper than vertical. Here we have less slope, and here we have really, really low, right? Not steep at all. And that's because we have a spherical object, which we have said in previous lectures gives you the most distortion. The least distortion at A is based on the fact that the geometry of this particular shape, and this is like sort of theoretical, because not every part happens like this, to pretty much match up exactly with the divergence of the beam. Right? So the closer you can match the divergence of the beam, the less penumbra you'll have, the steeper the slope will be on these trace diagrams. Good? Good?
Go back to the slide right before. The steeper the slope, the less horizontal spread, sharper the image.
Yes. So it's kind of like, you think of it as a less horizontal spread of penumbra. Okay, finally. All right, spatial resolution. I have like less than 10 minutes. Definition, basically the ability to distinguish objects from each other, right? Kind of like going out on the beach, picking up some grains of sand. If you can count the spaces between the sand and actually be able to count, that's good spatial resolution. Right? This is actually a bad image, right? Because to me, this image is more like contrast resolution. Spatial resolution would be if the apple was green and you could count all the apples. You know, where they start to merge into each other, like we've done a lot of labs like this, where the lines on the test tool start to blur, like on this, then your spatial resolution is going down, right, when you can't tell them apart. So we've seen this before. Spatial resolution can be recorded, at least graphically, by taking an image along with the test tool, line pair resolution test tool. And we can look at what's known as the spatial frequency. More on this word in a second. As we've discussed previous labs and classes, we measure this by counting, literally, line pairs per millimeter. The more line pairs that you can count, the better your spatial resolution is. Another way to say this is the better chance you have of resolving an object that you might be looking for. At a certain point, you can't resolve an object. It's technically there, but if you can't see it or it doesn't manifest on an image, then it's not there for all intensive purposes, right? CAT scan, X-ray, every modality at a certain point fails, right? Especially when things get really, really tiny, which is where nuclear medicine comes in sometimes, to look at things on a molecular basis. So this one is important. The smallest object that can be resolved is inversely proportional to what we call as one half the spatial frequency. So you will have a question where the spatial frequency is given. Well, let's just do one because it's on the next slide. Okay, so you'll get a question that sounds like this. What is the smallest object that can be resolved if you have a particular X-ray machine that is known to have a spatial frequency of 3 line pairs per millimeter? That doesn't mean that you can see something that's a millimeter. It doesn't mean that you can see something that's 3 millimeters. So don't let the actual question, it would be great. You wouldn't have to do any math. It would be really easy, right? So what you have to do is you have to take the 1/2 stays the same, right? And it becomes 1/3. So let's go back, right? This is the missing item we're looking for, right? So it's 1/2 times 1/3 because it's 3 line pairs per millimeter. This is the spatial frequency. We're all on the same page? Okay. Then it's easy. You just multiply across. 1 times 1, 1. 2 times 3, 6. Divide, because we don't like fractions. And then we could say that the smallest object that a particular X-ray room that's known to have 3 line pairs per millimeter is 0.17 millimeters. So if the object is 0.12 millimeters, can you resolve that object? Answer, no. Is that object still in you? Unfortunately, maybe. If it's bad, yes. If it's good, maybe that's still bad. I don't know. But that's how you do those. MTF, or modulation transfer function. What time is it? I'm going to go like 5 more minutes. Is that off?
Crazy. It's spinning like nuts.
Oh.
We're in a time warp.
Oh, I have 3 minutes according to my watch anyway. All right, MTF. Yeah, we've been here for 3 hours now. Okay, it might feel that way. I know. All right, so we're getting to some of the more complicated stuff. So it probably needs a battery.
I'm really flat.
Yeah, I thought I was having a flashback. All right. Flashback to when I was in college. Okay. Yeah, there was one day where I woke up with a side view mirror in my bed with me. It's really weird. Yeah. Don't ask. Okay, so modulation transfer function is the measurement of the ability of an imaging system to take these alternating signals that we're collecting and essentially turn them into the different brightness levels that are attributed to pixels. So if you take a look here, as the lines become smaller and closer together, so we're looking at the wavelength. So this has become closer together from A to B. What's known as their rounded penumbral edges begin to overlap. So we're seeing that at C here, right? And this whole thing starts to look like a sine wave, which really A, B, and C all look like sine waves to me. So they become smaller and close enough. So what happens is at a microscopic level, the depths of the troughs, so that's the bottom parts here, start to come together and merge with each other, right? And then when that happens, you start to lose resolution, right? So contrast begins to be reduced between the lines, and you are less able to manifest that on an image. So if you see at B, you're looking at, let's say, an object that can be resolved. And the example here is that at 1 centimeter, you can resolve the object, right? But at C, where now you've gotten to an object that is 0.8, a little bit less than a centimeter, you're getting to a point where you can no longer resolve that object in this example. Here's another way of looking at it, right? We say that MTF is really the comparison of the contrast that's in the image versus the contrast of the actual object if you were to rip it out of the patient and look at it. So when you say that the MTF is 0.5, because remember, I think we went over MTF scale. It goes from 0 to 1 by tenths of a point. So 0 would be no representation of contrast of the object is translated to the actual image. So a 0.5 would be half the contrast of the actual image is translated to the object, translated to the image, excuse me. So what you would really want is the highest MTF possible. If you were to have an MTF of 1, which is impossible, right, for a lot of different reasons, that would be perfect contrast of the object translated to the contrast of the image. That would be great, right? So what we're seeing here is MTF values start to become smaller and smaller and get closer together. So here you have an MTF of 0.8, but it keeps going down and down and to a point where you can't resolve and don't have the object information that you would like. Contrast resolution and MTF. So modulation transfer function on this graph is here you have MTF on the Y vertical, spatial frequency on the X, and we're comparing A to B. So system B has both a higher MTF. So let's see, at 0.5, we should do it this way, right? At, let's say, a spatial frequency of line pairs per centimeter at 4 yields an MTF of whatever this is, right? A little bit more than 0.1, maybe it's 0.2, right? 0.2 would be here, right? But at 4 spatial frequencies, system B has a much higher MTF. You guys see that? It also has better spatial frequency. So at a 0.5 MTF, A gives us a spatial frequency of, I don't know, like 3. And at 0.5, system B, if we go across, has a higher spatial frequency. We went from 3 to maybe 5-ish. Pixel size, I'll leave it at this. And then what I'll do is I'll make sure I'll check my current recording from last year, but I'll also fill in the other recording. But I just want to make this last point. So the spatial resolution is often limited by the size of the pixel. So if your pixel, for example, or what's commonly known as your detector element, is 0.1, then you can't see anything that's less than 0.1, right? You can only resolve an object that is as big or bigger than the individual size of a pixel. That's a problem, right? But the bigger problem we have in X-ray is that our spatial resolution, regardless of the pixel size, because the pixels are pretty small, is going to be affected by, or the word really should be limited by the focal spot itself. So if the focal spot is 0.5 or 1.2, somewhere in there, then it doesn't matter if we have a 0.1 or 0.2 or 0.3 or 0.4 size pixel. It's the actual diameter of the focal spot that becomes the limiting factor, right? So the computer systems are starting to get better and better, but until we can reduce the actual focal spot, we're going to be limited in our resolution. So I'll leave it there. I don't think we had too much left. Oh, one last slide?
Or not, it was a picture. Yeah, that number 44.
Oh, okay. So I'll do this one. But you can, if you want to leave, you can. This way I don't have to create another recording. So there's a big trade-off between contrast resolution and spatial resolution. It's really hard to maximize both of them. This is a concept in CT as well as X-ray. It's really hard to get the best spatial resolution and the best contrast resolution in the same image, right? One of the things about that is we've learned probably, I hope, that the more pixels you have and the smaller they are, the better your spatial resolution. But at the same time, when the pixel becomes smaller, what's known as the voxel, which is the third dimension of the pixel, it's a volume element. So it's like a sugar cube. The pixel is if I take the sugar cube and put it so close to your eye that all you see is the square and you can't really see the rest of how far the cube is. But if you think of this cube, which is representative of slice thickness, if you think of that cube as pouring information into it, when the pixel gets smaller, thus the voxel gets smaller, then you have less signal, less information in that given area. When you have less signal, you get less contrast. So spatial resolution goes up, but contrast resolution goes down. Okay, now we're complete.
What's on this semester? 1 o'clock.
I told you this semester will be fun.
Yeah,
Reading.
That's super crazy.